And thank you, Dr. Ruben. He covered most of the things that we'll cover today in my presentation, and they share his experience in England, and we'll share our experience at national level and at the KFMC. So my presentation about setting up an anticoagulation clinic and the role of clinical pharmacists in that clinic. So my outlines to have an introduction about anticoagulation clinic and how to set up that clinic, and we'll have an overview of current anticoagulant and the old anticoagulant compared with the new anticoagulant, and what is the challenges in the new anticoagulant, describing the clinical monitoring of the current anticoagulant, and the role of clinical pharmacists at the end in the anticoagulation clinic. So as Dr. Ruben mentioned, we'll all focus on the clinical multidisciplinary thrombosis services to give highly specialized services. So our objective in the clinic is to provide specialized services in thromboembolism, prevention, detection and treatment that is essential for a tertiary care institution. So why this project is needed? So to have like standardized guideline and protocol to appropriately treat thromboembolic disorders. We'll have like internal and external referral in the clinics. We have like complicated thrombosis cases to treat in the clinic, so we need a multidisciplinary team. We have to provide evidence-based recommendation for prevention, diagnosis, and treatment of venous and arterial thromboembolism whenever possible. Establish national registry and thromboembolic disease in the kingdom, and the first TTE treatment registry in Saudi Arabia. And we have the first home health care thrombosis program in the kingdom. And we have the collaboration in the national and international multi-center research projects. So we have our collaboration with the other services, with the dental department for operation and the dental procedure. We have the pharmacy and cardiology collaboration. We have a VTE prophylaxis committee. And we have other things that the protocol and guidelines for like a thrombolytic therapy guideline for massive BE. And we have our training program in the clinic. We have the fellow and the clinical pharmacist will participate in the research and the activity in the clinic. We'll focus on the diagnosis of the thrombophilia, management with anticoagulation clinic, the old and new anticoagulant, and management of the VTE disease in patients with high hemorrhagic risk, diagnosis of the resistance to antithrombotic treatment, management of antithrombotic therapy in cancer patients, and management of preoperative bleedings. So we have our training program in the clinic, which is led by Dr.sheef. And we have our KFMC VTE prophylaxis committee. So each patient will have this protocol in his files to assess the patient and what's the need of the prophylaxis, what kind of prophylaxis the patients will need at that time. So as a summary of all these slides, I mentioned that scope of anticoagulation clinic services to have a specialized thrombosis clinic, consultation internal and external, education and training, home health care program, and research. So our OPD pathways, the outpatient pathway, that the patients will come as a new patient, will attend a new anticoagulation, the specialized anticoagulation clinic. So we'll do the screening and treatment and the bridging anticoagulation and follow-up there. So to set up an anticoagulation clinic, what's the required resources? So we need to have a point of care for coagulate check. We have highly specialized laboratory services. We have OPD space. We have full-time clinical pharmacist, full-time thrombosis nurse, full-time health educator, full-time coordinator, clinical investigator, data manager, computerized INR monitoring, which is our plan to have it, electronic VTE prophylaxis orders, and home care nurse. So it is like a huge effort to have like a multidisciplinary clinic, so to have a specialized services to the patients. So in the clinic, those patients that included in the clinic, the patient with the venous thromboembolism, either DVT, BE, or DVT with BE, or BE. We have unusual site thrombosis, like subclinic venous thrombosis, cerebral venous thromboembolism. We have like hereditary acquired thrombophilia. We have thrombosis in pregnancy. We have massive and submassive pulmonary embolism. We have gynecological malignancy-associated thrombosis, and we have stroke in young age. The exclusion criteria from our clinic, so we have stroke prevention and atrial fibrillation, mechanical heart valve and anticoagulation, and VTE in non-gynecological malignancies. So this is our pathway, our clinical pathway. If the patients, as a first visit, referral diagnosis, If it is yes, we'll have like a history and the method of diagnosis and the treatment. If it is no, we'll confirm the diagnosis with the diagnostic method. If it is follow-up case, we'll see that is the patient would have any bleeding or any sign or symptom of thrombosis, so we follow that one as a follow-up visit. So we'll have our like overview of the current anticoagulant in anticoagulation clinic. So as a pharmacist, I will just mention and cover it quickly, as you know that the old medication, that warfarin, all of us knows like since like 60 years maybe. We'll have that patient the medication need to be bridged for 5 days with the low molecular or unfractionated or heparin or fondaparinux. Then to start with the overlap with the patient overlap with the vitamin K antagonist for 5 days. Then we start to continue with the warfarin. So we know that's warfarin. What's the warfarin? We call it that as a mechanism in the pharmacy. They teach us that it is 1972. That affect the proteins like protein 2, 7, 9, and 10, and protein C and S. So it affects these proteins. So why we need to bridge like 5 days? Because of this inhibition of these factors. Like factor 2 need to 60, 70 hours. That mainly like take 5 days. And factor like 7 half-life have 6 hours. So your patient is still prothrombotic until INR reach more than 2. So what affect warfarin? So as a pharmacist, we need to know what's things that affect warfarin. So we know that's drugs, herbal, gender, liver disease, other diseases, body surface area, age that affect warfarin. And even other medication like common medication, over-the-counter medication, antibiotic, non-steroidals, the common over-the-counter medication here, especially in Saudi Arabia, for use of antibiotics. So that affects the warfarin and monitoring of the INR, despite the other medication the patient will take from other clinics. So as recommendations, to avoid concomitant use of non-steroidal and COX with the anticoagulation with warfarin, and even though the antiplatelet should not be used with or used in special situation like cardiac patient with ischemia or non-ischemia, ACS, that develop AFib, maybe need combined triple anticoagulant, but commonly we don't use the antiplatelet with anticoagulant together. And the things that affect warfarin, the genetics. So polymorphism in the gene of cytochrome B450 and the vitamin K bauxite reductase complex that affect even the warfarin. So when you speak about cytochrome B450 and the CYP2C9 that's affected, so we have like 2C92 and 2C93, which is 12% in the Caucasian, the 2C92, and 2C93, which is 6% of the Caucasian. So the recommendation is to have lower initial and maintenance doses of warfarin required for those patients who have hereditary or genetic mutation in this gene. And what about the other gene, which is FK or RC1? The patients with Caucasian, like 36% affected. So higher doses of warfarin is required in those patients. But is it recommended to have like genetic testing for those people? It's not. It's not a usual recommendation, not a usual practice to test those patients for genetics as initial treatment with warfarin. So we have a key point about monitoring of warfarin. So we have like different guidelines, different articles, different references for monitoring of warfarin. So I'll highlight like we start warfarin, some of the recommendations they start with warfarin with 5 milligram and so on. They monitor the INR. And some of them, they start with 10 milligram as a beginning, then they monitor the INR and they adjust the dose accordingly. And if you see that recommendation from ACCB in 2010, they start warfarin with 10 milligram daily for first 1 or 2 days, and will lower dose with the elderly patient. But we suggest, the suggestion is to initiate vitamin K antagonist daily for 2 days, then they follow up and they change the dose according to the INR readings. In our clinic, we practice like 5 milligram. We give patient 5 milligram and we monitor for 3 days, then we monitor and we change the dose accordingly. For patients with antiphospholipid syndrome, with a previous arterial or venous thromboembolism, The suggestions that the vitamin K therapy titrated to moderate intensity INR, which is 2 to 3, and despite the use higher intensity, which is 3 to 4.5. And here again, that's the IV and subcut medications and the monitoring of them, the heparin, the enoxaparin, and the dose adjustment in the renal impairment, as it's covered in the previous presentation with the previous doctors and the renal dose adjustment. And regarding the maintenance, make sure that if you have like just one reading between the therapeutic range or outside the therapeutic range, dose change may not be necessary. So as it is significantly outside of the therapeutic range, which that means more than 0.5 change in the INR, we increase or decrease the total weekly dose by 10 to 15%, this is about warfarin. So we don't change the dose with only one reading outside the therapeutic range. And Dr.sheef mentioned that different modalities to manage the bleedings with warfarin and other treatments, so I will not cover this one because Dr.sheef already mentioned that management of bleeding and supratherapeutic INR in the warfarin. So high-quality anticoagulation clinic, there are many observational studies that have demonstrated improvement in the time and therapeutic range, which is as well as accepted surrogate marker of good anticoagulation clinics. So there is a systematic review of 67 studies found anticoagulation management services had a mean time and range measured by the linear interpolation methods of 65.6% versus 56.7% with usual care. And here that we don't forget the educational materials that we give the patients, which is in Arabic version for the patients. And we have this booklet for monitoring of warfarin. We write the dose, the previous dose, the change, and the last INR reading if they can go to other clinics or can go to other hospitals, so they have the reading with them. And we have our plan and protocol that if the patients want to stop the medication before the plan for stopping the medication before surgeries. And we have the letter to the dentist, and we are in collaboration with them if they want to do a procedure and the patient in warfarin. And it's our plan to have like computerized INR monitoring, like down anticoagulation AC, which is computerized anticoagulant dosing package, which has been in operation for 18 years and used by 290 centers in 14 countries worldwide. So that to provide a benchmarking, so most significant markers being a percentage time and therapeutic range with these programs. So that these computerized INR monitoring will help us to reach the target of TTR. And we have other computerized INR monitoring, which is abroad. And the automated program for oral anticoagulant treatment randomized trials, the computerized dose adjustment significantly improved the TTR as compared with usual care, which, as you can see, that's 71% versus 68%, which would be value less than 0.001. And we don't forget that we are in the era of new oral anticoagulants. So we have the challenges for the new oral anticoagulants in anticoagulation clinics. So what about anticoagulation clinic in the era of NUACs? So anticoagulated patients will still need care. So we'll assess the compliance, we'll monitor the progress, we'll determine the duration of anticoagulation, we may need to monitor the renal function and the bridging of anticoagulation. So patients who are rock solid, stable on warfarin should not be switched to new anticoagulants. So why to switch to NUACs? Either to have extreme spike in the INR and TTR below 58, warfarin is not effective intervention when TTR is less than 58%. Patient unable to attend the anticoagulation clinic. Patient who had intracranial hemorrhage due to high INR. Patient who had ischemic stroke while taking warfarin. Patient or physician preferences. And why to switch back to warfarin? Patient with renal impairment, patient with mechanical fast who cannot start a new oral anticoagulant, and no evidence of that. Low compliance is suspected despite proper education. and patient or, again, physician preferences. And here's the slide that shows the choice of anticoagulant based on patient characteristics. So we have certain characteristics, like patient in the renal impairment, what's the choice? And like patient with gastrointestinal bleeding, that's apixaban, while dabigatran have increased bleeding, and even the current data that say maybe no with the dabigatran, but still the evidence with the change, the dabigatran has higher gastrointestinal bleeding and other indications. So this schedule that show you the choice of anticoagulation based on the patient characteristics. And note that the initial parenteral anticoagulation should be given before dabigatran and edoxaban, and is not given before rifaroxaban and apixaban, and it's overlapped with vitamin K therapy as per guideline, CHEST guideline 2016. And this is the CHEST 2016, the duration of anticoagulants that they mentioned. They have three categories: long-term, which is 3 months, at least 3 months, and extended therapy, which is no stop date. So for long-term, which is 3 months for patients with provoked and patients with unprovoked with high risk of bleeding. And for at least 3 months for patients with unprovoked, and we will assist after 3 months. And for extended therapy, no scheduled stop date for unprovoked, proximal DVT or BE with low moderate risk of bleeding, or second unprovoked with low moderate bleeding, low or moderate risk of bleeding, and if the patient will have active cancer. So active cancer, even with the high risk of bleeding, will continue with the extended therapy or no scheduled stop date. Now my part, which is the pharmacist who like it. So a role of clinical pharmacist in anticoagulation clinic. So as a history of our clinic, so we start in 2006, all patients that seen with the internal medicine consultant. Then we moved to 2009, 50 patients with Dr. Sambach at that time. And 2010, Dr.sheef and Dr. Sambach increased the number of the patients up to 250. And we have like VTE Prophylaxis Awareness Symposium, the first one in 2011. And we have multiple works that over the years. And in 2014, the introduction of clinical pharmacists in the anticoagulation clinic. So do we have a role in the clinic as a pharmacist? Over the past 40 years, major changes have occurred in the area of anticoagulation management. New strategies have been developed for older anticoagulants. Older beliefs have been challenges. New anticoagulants have been introduced. And new indications have been identified for existing anticoagulants. So the role of the pharmacist in managing anticoagulant therapy has been established, and clinicians have learned more about the critical importance of medication safety. So this is JCI, the Joint Commission National Patient Safety Goal Requirement. They say that the anticoagulant is a high-risk treatment, which is true, which commonly leads to adverse drug effects due to the complexity of dosing of these medications, monitoring their effects, and ensuring patient compliance with outpatient therapy. So the role of clinical pharmacists is here. So we are the best to know about the medication, so as you can see from this quote. And over the last 2 decades, the benefit of pharmacist-managed anticoagulation therapy has been well established. As you can see, in 1985, and there is one study that say that therapy managed by pharmacists resulted in an improvement in the percentage of prothrombin time and INR in the therapeutic range, and reduction of hospitalization for thromboembolic or bleeding events. So the pharmacist has a role in managing anticoagulation even in the inpatient setting. So there is one study that say that an evaluation of over 700,000 Medicare patients from almost 1,000 hospitals found that those without pharmacy-directed heparin and warfarin management had higher mortality rates, length of stay, Medicare charge, bleeding rates, and transfusion requirements. So what's our responsibilities in the clinic? As the ASHP say that our rules, that our responsibility is to perform patient assessment for medication-related factors, order laboratory tests necessary for monitoring outcomes of medication therapy, interprets data related to medication safety and effectiveness, initiate or modify medication therapy care plans on the basis of patient response. And the most important thing is that provide information, education, and counseling, which is the best, to patients about medication-related care. And we need to document the care provided in the patient records, identify any barrier to patient compliance, which is a major issue with the medications, the compliance. We participate in multidisciplinary review of patient progress, and we communicate relevant issue to physicians and other team members. The last thing, we did one study since we started in 2014 about enhancement of anticoagulation clinic by clinical pharmacists at King Fahd Medical City, which is a pharmacy-led multidisciplinary performance improvement project. We see that there is a lack of clinical pharmacist involvement in the anticoagulation clinic. So we set a desired KPIs that we see that 30% of total numbers of patients will be seen by clinical pharmacists, 70% from total numbers seen by clinical pharmacists within therapeutic range, which is between August 2014 till January 2015. 90% from all patients seen by clinical pharmacists have been an improved awareness on their anticoagulation therapy, and 70% from all patients seen second time by a clinical pharmacist are within therapeutic range. So we put an action plan, we develop a thrombosis team, we develop a clinical pathway for DVT and BE and thrombolytic therapies, we develop monthly clinical pharmacist inpatient coverage, and we have prepared an educational material regarding the counseling about the medication, and we prepare a satisfaction questionnaire to the patients. So what we do, we start the monthly clinical pharmacist inpatient coverage. We prepare educational material, as I mentioned. We start to cover the anticoagulation clinic as twice per week, which is the schedule for the clinic, which is Sunday and Thursday. And we did a satisfaction questionnaire was distributed to the patients. So the measurement of improvement and effective of changes. We follow that 182 patients seen by clinical pharmacists at that time. And you can see the distribution of age, and we have around 70% female. And this is the diagnosis at that time that we see. Most of them are, as you can see, DVT or BE, or lower DVT, or patients with recurrent DVT and BE, which is the most common diagnosis. Type of medication, that's the most medication that's used is warfarin, and the second is 20% is rifaxiban. And the type of intervention that we did as a clinical pharmacist, either we continue the same dose, or we change the medication, or the medication need to be adjusted. As you can see that 114 patients checked by clinical pharmacists, and 74% within the therapeutic range. And compared with the physician, that 114 patients checked by the physician, they are 73% within the therapeutic range. And all the result is comparable with the physician at that time. So we did a comprehensive education for all the patients, and as you can see, there is 3.3%. They say that no, they don't have education because they are following a long time in the clinic. And we did a satisfaction questionnaire. We reached 93.3% satisfaction about our services as a clinical pharmacist in the clinic. And the patients that's seen as the second visit in the clinic, we have 15 patients in the warfarin group, and 12 patients continue the same dose, which is 80%. And in the physician side, 15 patients seen, and 12 patients in the warfarin group, and 25% they continue the same dose, which is within the therapeutic range. So the KPIs, the results that we have, we reached above the KPIs that we set. The 35.9% that initiate pharmacist anticoagulation clinic at the KFMC. We have 74%, which is exceeds the 70s. INR within the therapeutic range. We have 93.3%, which is increasing the quality of life and raising the awareness when using anticoagulation medication, which is the satisfaction. And we have 80%, which patients come as a second visit within the INR within the therapeutic range. So my take-home message: we are a multidisciplinary team. We are working together. Consultant, physician, pharmacist, nurse, and investigators, coordinator, all the team members. We are one team, as a multidisciplinary team. And as Dr.sheef always say that as one person, we'll move one step, and as a group, as a team, we'll move 10 steps in front. So by that, I conclude my presentation. Thank you.